be asked to keep presentations within preset time limits. Also, members, please ask for permissions from the chair before speaking to ensure that microphones can be activated. For our virtual public participants, you will be muted and your video kept off until it is time for you to provide public comment. This will ensure the board manager's video feed remains visible at all times as required by state law. When it is time to provide public comment, your microphone will be unmuted and you will be invited to turn on your video if you so wish. Public communication. The first item of business is public communication. We will receive public communication for both the Executive Committee and the Board of Managers meeting before we proceed to the committee agenda. Members of the public who wish to make comments during the public communications portion of the meeting must have registered with Central Health via the online form or by telephone no later than 3:30 p.m. today. Yersinia, did anyone register to make comments for either the committee meeting or the Board of Managers meeting?
Yes, Mr. Chair, we have 3 members of the public who wish to speak.
Then please go ahead.
Perfect. I will now read the guidelines for this meeting's public communication. When called upon to speak, please introduce yourself by name before beginning your comments. Also, if your comments will focus on a specific item or issue on the agenda, please indicate the full item number. Each speaker will be limited to 3 minutes. Staff will be timing each speaker and will announce when the speaker has reached their time limit, and I will be holding up a 30-second sign. Due to the restrictions of the Open Meetings Act, the board may be restricted in discussing any items that are not listed on the agenda for this meeting. The board may choose to set aside any new issues for discussion at a future meeting. We received 2 submissions for public comment via our online portal and 1 through voicemail. At this time, I will call on our first public communication speaker, Mr. Jeronimo Rodriguez with Ascension Seton.
Good afternoon, Board of Managers and Chair Bell. My name is Geronimo Rodriguez, and I serve as the Chief Advocacy Officer for Ascension Seton, and I'm calling on item to the regular board agenda, item 1, in support of a 2.35% increase in the LPPF rate, which will bring the rate up to 4.71. And just wanted to share our support and our appreciation for the partnership with Central Health to ensure that we're providing care for the poor and the vulnerable. Thank you all very much.
Thank you very much, Mr. Rodriguez. We appreciate those comments.
Thank you. Up next, we have Manager Cynthia Valadez.
I just ask a question for clarification.
Manager Valadez?
Yes. Before I start, are we not going to have public communication before our board meeting, or is this it for both meetings?
Manager Valdez, this is it for both meetings. We've
Okay.
decided that since they're both posted at the same time and location, we can combine them.
Thank you. Thank you all for allowing me the opportunity to speak today. I only have 2 short notes that have been sent to me. One from Commissioner Margaret Gomez, which I will read into the record. It says, from Margaret Gomez to Cynthia Valadez, please let Central Health board members know that I'm asking them to approve Medicaid for Sendero, especially since they are poor. Medicaid for Sendero clients will help Central Health meet their mission of serving poor and underserved clients. And it was sent today from her iPhone.
Thank you.
And the second is from Commissioner Bridget Shea. Hi, Cynthia. Thanks for reaching out. I support letting Mr. Cease speak to the Central Health Board tonight, and I urge you to support the expanded funding and access to health care. And this is for Sendero. So these are the 2 comments that I'm reading from Commissioners Margaret Gomez and Commissioner Bridget Shea. Thank you very much.
Thank you, Manager Valadez. Just as a comment, we have invited Mr. Cease to join us in our discussion. If he is able to make it, he will be here. And secondly, we will not be taking a vote regarding Medicaid at this point in time. And I will explain that more when we get to the agenda item. Next, Yesenia.
Thank you, Mr. Chair. Lastly, we have Central Health President and CEO, Mr. Mike Giesland.
Yes, thank you. Members, last week, we reflected on the memorial for the Buffalo shooting. Yesterday, Uvalde. These mass shootings have a tremendous cumulative effect on individuals because of the hatred and the racism. And it is beyond words in trying to explain what this means. But we want both Buffalo and Uvalde to know that Central Health is here for you. We grieve for you. We mourn. And so if we could just take a brief moment to honor those lives. Thank you.
Thank you, Mr. Giesland. Yesenia, any additional speakers?
And that is it on my end.
Thank you very much. And thank everyone for their comments. We will now proceed to the executive committee agenda. Agenda item number 1, review and provide direction to staff on the prioritization and tentative scheduling of items for consideration at and method of conducting future Central Health Board and committee meetings. Brianna, will you start us off? And I think Perla will also assist.
Yes, I'll start off by going over the June tentative schedules. So for June strategic planning, we are going to have a deep dive on fiscal year 2023 strategic priorities, and then an equity-based systems planning phase 2 update implementation plan, including operational and financial details. For executive committee, we will discuss tentative schedules, and then we will have an integral care strategic alignment conversation and a Sendero strategic alignment conversation. For the regular board meeting, we will have financials, investments minutes, and then we'll have HR updates and the Dell Medical School update. And I will pass it on to Mr. Giesland.
So there's a couple of notes on upcoming agenda items. Mike, please. Members, a couple of notes on upcoming agenda items relative to June, and then potentially that pushes into subsequent months. On the workforce reporting, we have a sample dashboard that addresses a number of issues that we reported on the board to the board before, but it's been revised and reformatted, but more importantly, it has been put in an active format where it'll be available on our website, as well as management tools on our intranet site, but also it doubles as reports for the board that you're accustomed to seeing in the past. And again, what you see is a PDF document that's in your packet. There have been some revisions as late as yesterday, and so it's subject to further revision. But we wanted to get this in front of you just to show you, this is what the HR team has come up with. And so we've gone from PowerPoint slides and screenshots from an internal HR software, back office software, to something that's Tableau based and a lot more informative and interactive too as well. And you'll see this whenever we take this live on our websites and present it to the board. You can hover over the different sections to get further breakdowns and disaggregations. So this will be coming to you for further discussion, but we wanted to get it on your radar screen now. Related to HR discussions that are also noted in the month of June, there are a lot of different reportings and I appreciate the board's patience, that we have been moving to subsequent months. Typically, we see those earlier in the year, but I want to commend our HR transition team, Rayette and Sherelle and Jeannie Verdon, and also Perla Cavazos and Mackenzie, who have joined as the non-HR member on the HR transition team. But we're working through a number of issues related to the organization and the functionality of the HR department that I think takes priority at this point in time, given what we need to do as an organization. And so therefore, we've pushed a lot of these reports to subsequent months, but we have not forgotten about them, nor does that de-emphasize their importance to this organization as we think about our culture. The second item, second larger item is all things real estate. And this pertains to future agenda items on the board. Because of the markets that we're in, things happen fast. You get notices of opportunities that while we might be thinking about these things in terms of 5 and 6 years from now, they may very well be a great fit today. And if you, going back to the health equity report that you all adopted on the 25th of February, if they line up with those board directives and imperatives, and obviously if it passes the, I see Jeff Canodal in the back of the room, the Jeff Canodal test in terms of being financially prudent, then we will be bringing these issues to you, but it will be at short notice because just as things come to us quickly, they also evaporate quickly. And so we'll need to be ready to act, even potentially in special called meetings. We're going to try to minimize that, but we can never predict when the phone will ring or an email will come across and there sits an opportunity that would be ideal for serving our patients, especially as we think about locations in high poverty and high health disparity regions, pursuant to our report. So just wanted to put that out there as a potential agenda item. It's a non-item right now, but it certainly could become one in a moment's notice. That concludes my remarks. Thank you.
Thank you, Mr. Houston. Any questions?
Mike, please.
So if there aren't any questions, then just a reminder, after June 15th, after the next board meeting, June 15, we're taking a small break and we will be back on July 27th for I believe a strategic planning committee and a board of manager meeting, unless there are any emergencies, of course. With that, Dr. Bell, did you want to bring up the topic of a retreat?
Yes.
Okay.
Members, first of all, I guess I should say good afternoon. I don't ever acknowledge you guys. I'm so busy trying to start this meeting and run it. So thanks for being here and welcome. I had sent out a request with regard to getting some input on doing a retreat for this year. And I sort of got one person who gave me information and provided me with a fairly long list of items that we could actually cover in a retreat. And I thank that individual. I got two individuals who said that they didn't want to have a retreat this year. And I had three individuals that said it didn't matter. And I had three individuals who didn't respond. So my thought is that at this point in time, it seems that the majority of the board would like to sort of delay a retreat at this point in time. No one feels extremely compelled to have one. So what I will do is send out another poll sometime in September or October and see if the feeling has changed. We can surely have one next year and, make some decisions as to what we want to discuss. But that seemed to be the will of many of the individuals who responded. And so I just wanted to let you guys know what the result of that poll was. Any questions or comments? Shannon.
I guess my question is delaying it until a decision in September. I understand the rationale, no problem. I guess my concern would be is that given all of the dynamics of what we're dealing with, especially as we look at long-term type of things, it seems to me that delaying it would not necessarily be the best decision. For those who didn't want to or didn't make a decision, I'm not sure why. Each individual has their own choice. But I just a caution, if we keep putting things down the road, given all that we're facing and will be facing perhaps over the next several months, a strategy session on what we are, where we are going, who we want to be, I think would be worthwhile. So I would encourage us to consider certainly not putting any beyond September, but at a minimum, if we could still get September, I would encourage us to do that.
And I would also like to say that, we can have a special call meeting that can do what you're talking about. That's not really a retreat, and have a discussion on necessary topics. It won't be a weekend. It'll be during the weekday, and it would be strictly devoted to particular topics that, the board feels needs to be discussed. I thought that retreat to me means sometimes on the weekend, you take a whole day, maybe a day and a half, and, meet and talk about not only board process issues, but, other strategic issues at that point in time. But if a special call meeting is something that we can pull together with specific topics, we will do that.
Thank you.
Manager Masaiti.
Thank you, Chair. I actually concur with having a special called meeting. I think it'll be more efficient for our time and the best use of our staff time as well over the weekend. So I definitely will support a special called meeting if we have a specific topic that we need to address and discuss that day.
Okay, we will work on developing what those topics might be, and then we'll do a poll to see who might be available for a special call meeting. Thank you very much. And I think the last item has to do with our meeting place.
Right.
We had spoken about ASID remaining our meeting place about 2 months ago, and we felt that we would make that decision a little further down the road because we didn't necessarily know where COVID would sort of bring us and what points we might be in the pandemic. I think we are reaching the end of our contract with ASID to have this
Yes.
space, and we need to come to a decision as to whether we would like to move back to the Cesar Chavez address, or if we are to see if we can remain here. I mean, I guess that would have to be negotiated with ASID. Am I correct?
Correct. And Brianna did reach out to AISD, and they do have the dates we need available at this time. So we could continue here, or we could go back to Cesar Chavez. We have done some minor upgrades to the boardroom technology. We now have better speakers and microphones and a camera so we can see your faces. I think those were upgraded about a month ago. So at our last strategic planning committee, we still had a little glitches, but we're working through those. And obviously the space is smaller, but we would love to hear your how you feel about proceeding.
I'll start at the end. Manager Greenberg.
I'm open to the will of the board. My concern would be the adequate technology. It did seem to have some issues at our last strategic planning committee meeting.
Thank you.
Well, I agree with the manager Greenberg. I'll do whatever the will of the board wants. I'm selfish. I would like to stay over there in East Austin, but I'm willing to come over here.
I'm with you.
Me too.
Manager Valadez.
I agree with the idea that we go back to central health if we have the glitches taken care of, but I didn't see any bigger glitch at central health during our strategic planning meeting than I have seen here at AISD every time we have a meeting that I've been present. So if I can't imagine that it's not cost effective for us to remain at central health. And those are our administrative offices. We need to use them. And I haven't seen that we've got overwhelming amounts of people attending our meetings in person. So the size of the Central Health boardroom shouldn't be of any great consequence. And I like the fact that it's centrally located and we are in East Austin. Thank you.
Thank you, Manager Valadez. I really have no preference, but, well, I take that back. I do have a preference. I would like to move back to Cesar Chavez, but again, I'll have to see what the consensus is among the board members. Manager Brinson.
Yes, I wish we had kept track of which site had the most glitches so we could, do this like this scientifically. But I think that since this probably costs us money, I think I'd rather go back to Cesar Chavez.
Thank you, Manager Brinson. Manager Musaiter.
Thank you. I agree with you, Manager Brinson, in terms of cost. We could probably utilize that money to something else to benefit our mission. But in terms of location, this is actually more convenient for me. One thing that some folks have reached out to me in terms of televising our meetings. Pre-pandemic, it was televised and it was easier for some individuals. Now some people are having a difficulty logging on to Ring Central. So I just wanted to express people's desire for us to televise these meetings again.
Thank you, Management Scientific. Manager Matwani.
I think as far as where we have the meetings, I defer to staff and the chair as choice. Outside of that, I'd like to thank Austin ISD for these facilities. I think they've been pretty great. And I wanted to shout out to any technologist out there who's been dealing with audio issues in any location, audio, video, separate inputs and outputs cascading over the same environment. It's really, really hard in a world of feedback. And just to shout out to everyone who's keeping it together. Thanks.
Thank you, Manager Matwani. Manager Jones.
I concur that it would be nice to go back to Central Health Office for convenience, for costs and others. But I want to make sure that we're not sending a message that by returning to Central Health that that the pandemic is over.
No.
And so I just think that if we choose to do that, we need to be clear that that's not the message we want to send. Secondly, I am still concerned with if we're going back, we're going to be facing the fall and winter months, and we run the possibility of surges again. So we might be back here again at a later date. So I just caution us to take those into consideration whenever we decide.
Manager Musaiter.
Manager Jones brings a really good point. So perhaps we can see the landscape of the summer, how things evolve by early September with our beginning a new fiscal year to assess the situation in terms of cases and with the flu season as well. And then we can move on if we have that time available for the next coming months. So hopefully by September, we'll be back in the office, but at least to give ourselves a couple months to assess the situation.
So am I hearing that you and Manager Jones suggested we stay here until September? Is that what I'm hearing, or what?
Yes, in terms of, because now it's May, July we're not meeting. So at least for the next month to see.
We are meeting in July,
we meet in
July
June, and we
27th.
meet in July.
Oh, sorry, you're taking that time up. I'm ahead of
You
myself.
may not be here, but we are meeting.
So what I am actually proposing, let's just give ourselves an additional month or two to assess the situation in terms of cases and also with the flu season as it arises. And there's another virus also happening. So that's what my proposal is. Let's just wait an additional month or two before moving. Again, it's whatever the majority, but I believe probably it's wiser for us to wait.
Okay, Manager Valadez.
Well, I appreciate your concerns, Manager Jones and Mustaita. However, I would like to see us go back to Central Health, and so if we can make a decision so that during the summer, let's say our next meeting, we know where we're going to be. Are we going to be here, or are we going to be there? If you are telling us, staff, that we are technologically not able to accommodate our meetings at Central Health, then tell us that. But if we are going to remain here at AISD because we don't know what we'll be facing, I'd rather us face them at Central Health. And if we have to come back, we always know that we have an open invitation to come back here and that we will be treated well by AISD.
I concur with Manager Valadez. I think that what I would like to see, I mean, I truly don't want any signal to go out based on our location as to whether an epidemic is or a pandemic is over or not. That's not the point. But I would probably suggest that we move the other way in the fact that we go back to Cesar Chavez, we evaluate things. If we see things getting worse, then we develop a contract to come back here. All right, as opposed to staying here for 2 more months and then looking and evaluating. And the flu season really starts in the fall. It doesn't necessarily start in the summer. So we wouldn't be gaining any information with regard to the flu during that period of time. However, since there seems to be not a major consensus, can I have a motion from Manager Valadez, please?
I'd like to move that we return to Central Health offices to hold our meetings. If staff believes that we are technologically able to do so. And as we see how things go, we can determine whether we need to remain there or move. But that is my motion.
May I have a second?
Second.
I have a second from Manager. I have a motion from Manager Valadez. I have a second from Manager Greenberg. Any further discussion? Hearing none. All in favor?
Aye.
Any opposed? I have one show Manager Jones opposing. Any abstentions? Show one abstention. Manager Musaiti. Thank you very much. The motion passes.
Thank you.
Thank you. Manager Jones?
Effective what date then will this become?
Our next meeting will be.
Based on the motion, I
Cesar
would,
Chavez.
right, we would start with June 15.
Okay, thank you. And that is all I have for that item. And I think that if that is all the staff have, thank you very much, members. We will go to agenda item number 2, receive and discuss community care health centers strategic alignment with Central Health Equity Focused Healthcare Services Delivery Strategic Plan, Healthcare Equity Plan. Members, during my tenure on the board, I've heard many members ask to have discussion with our enterprise partners. I felt that in lieu of a one-sided presentation, we would have a dialogue regarding major strategic issues that their organizations are addressing, and we will attempt to limit this discussion to 30 minutes. The questions that I throw out there as being important to address in this dialogue is, how can Central Health assist in addressing your organization's strategic issues? And knowing that, sometimes we do things that are not necessarily, that have unintended consequences. What may have Central Health done to create strategic issues within your organizations? And are there issues on the horizon that you guys are monitoring that you need to share with us and that we need to share with you? Also, with the publishing of our healthcare equity plan, what are the areas where your organization can provide assistance in addressing some of the gaps identified? And what are areas do you feel might be challenging for your organization to either implement or deal with? Mike, is there anything else that you would like to add to that?
Yes, sir. Thank you. Last night, just for the board's awareness, we, Monica, Allen, and John Morgan presented to the Community Care Board of Directors on the Health Equity Plan that you all have adopted, as well as this current fiscal year's priorities. And also just a thanks to Jason and your team for being contributing participants in our health equity planning process. You didn't just show up, you showed up with ideas and insights. So thank you very much.
Thank you, Mike. Now I'd like to thank Dr. Coopwood, who is chair of the Community Cares Board of Directors, and of course, Jason Fournier, who is the Chief Executive Officer. So to start this off, I'll sort of let you heard my questions. If you want me to repeat them, I can, but I think you got a little bit of a copy before you got up there, so you might be ready to talk.
We're always ready to talk, sir. So it's our distinct privilege to be here this evening with Central Health's Board of Managers. Greatly appreciate your work, your efforts on behalf of the communities we serve, as well as the efforts of your staff. There's so much alignment between what we do each and every day at Community Care with Central Health's core mission of ensuring that uninsured Travis County residents who are low income have access to the health care they need and deserve. I think by quick way of background, our board of directors back in January under Dr. Coopwood's leadership, as well as his peer board members, the majority of which are patients of our health centers. That's one of the unique things about a community health center is that the patients actually are the majority composition of the board. Helped us formulate our next strategic priorities from 2022 through 2024. And it really built off the last 3 years. At the core of the previous strategic plan, as well as the current strategic plan, is advancing equity and in particular advancing health equity. So everything within our strategic plan has at its core advancing health equity. Actually, our vision, as approved by our board of directors back in 2018, is striving to achieve health equity for all, and in particular for the communities and patient populations we serve. We have 5 strategic priorities for the next 3 years. The very first one, as I mentioned, is health equity. And it's really targeting to the most highest needs areas within Travis County. And then, of course, for us, we serve outside Travis County as well, targeting the highest needs area and doing that with actionable data, both from our resources and then from available data within the community. And that's inclusive of not just direct provision of care, but associated and augmentative services such as social determinants of health, issues that confront our patients. When we as a community health center have done more assessments on a health risk assessment than any other health center in the state of Texas, not in the country, but in the state of Texas. We're well over 120,000 health risk assessments completed. The number one need continues to be pharmacy identified, which might surprise you, especially considering that we, with your support, and a very robust pharmacy department, have one of the most expansive pharmacy programs in the country for a community health center program. But that also speaks to the need for a greater access to life-sustaining medications, right, that are available. So there's still opportunity there. Secondarily, then, is going to be food insecurity. Coming at about 17% of our patients reporting that, 21% pharmacy, and then transportation at about 13%. So the equity is looking beyond just direct provision of care, the scope of primary care, specialty care, all of these things that were very much articulated in the report that was provided to you by Guidehouse and which you approved as a board on February 24th, if I recall correctly. Around that, though, is the second. I'm going to kind of do these in order of priority, although equity is at the focus. The next is workforce. For us, it's key. And this comes to some of the questions, Dr. Bell, that you were asking in terms of your support. Our budget is roughly $170 million a year. 55 million or so comes to us through our contractual arrangement for services, the vast majority of which is direct for fee for service. Some of it's pay for performance, quality outcomes, some community benefit wrapped in there, but a lot of it is based on the services we provide and earn. So the rates that are provided to us are extremely important in our financial viability and going ahead and improving our ability to support our staff. One of the things that with the support again through our board is we articulated last year for the very first time, not only a compensation philosophy, but a plan, and we've acted on it. And in so doing multiple times to bring our teams up to market rates, all of our teams, excepting our executives, up to market rates relative to the community at large, with independent assessments done by our enterprise human resources department through assets that we brought in collectively to do that. The biggest strain that we've had as a result of COVID-19 and the change in economic conditions, not just locally here, inclusive of affordability, is retaining high quality staff, which we need in order to provide the quality of care. So mindful of those budgetary needs, I think it's important for you guys to recognize that our community, more so than anywhere else in the country, is accelerated competition for talent at a time that there's already large and high level competition for talent on the healthcare side. By way of example, a short 3 years ago, we were paying medical assistants $15 on average when they started with us. That now is well over, and I don't want to give the specific details because it's public, but it's over $18. In some cases, we're at the market or a little bit above in some of the positions, the highest need positions. That's our medical assistants, our front office receptionists. That's also inclusive of our patient service representatives. So workforce, our ability to provide the quality of care that we've become accustomed to, and to be able to support what last year was 125,278 unique patients coming through our doors. The ability to do that's directly tied to our workforce. And our board's been very supportive of that. We've invested, just for your awareness, $8 million more this last year in staffing adjustments to maintain our competitiveness. That stated, since COVID-19 started, our front office staff, the medical assistants in that, we've seen over 60% turnover. That's burnout, that's changeover. Once we get beyond 2 years, our staff are very stable, but that first group of folks coming through, very important for us to stabilize, right? So that's something I think as Central Health moves into direct care provision, which you certainly are going to be doing, is something that alignment across the board, because we're all Central Health employees, is going to be important. Another is resourcefulness, making sure that we're being not only innovative, but being very thoughtful and deliberate with how we use our limited resources, right? And so the board has charged us to do that with very specific quality outcomes, both on the patient outcome measure side, clinical, but financial as well, making sure we're leveraging those resources that are put into our charge very highly, but also looking and maximizing and optimizing all opportunities around us, which means as we continue to add services, to diversify those services, to incorporate things like pharmacy, which we're doing for the very first time. We'll have a drive-through thanks to your support and partnership at our soon-to-be next year Del Valley Health Center is a drive-through pharmacy, which will help address a longstanding pharmacy desert need in that community, but also candidly is a way for us also to draw in additional patients to help support the care at that site. So making sure that we're maximizing and optimizing those resources, be it on the Medicare side, Medicaid side, so we lessen the burden as it relates to the provision of costs financially for uninsured patients. Quality of care, our plan is always going to have quality at the heart, right? We want to drive equity by making sure that we have the highest quality of care. But for us, it's more than just looking at a one-year snapshot. And I think that's where, when I look at the plan that you guys are putting forth and the unique opportunity within Travis County, because of the healthcare district, is to take a longitudinal approach, not just now. Investments we make now can have and pay dividends 3 years, 5 years, 10 years down the line that lead to better life outcomes and longevity, of which we know there's significant longstanding disparities within the community, right? When I-35 right now today is an 11-year difference, if you're born and raised east of I-35 versus west, that is something that's critically important for us to recognize. And it's not something that we can lose sight of as the numbers change, because our community is going to be continuing to change demographically, and as a result of gentrification, our low-income communities that are very deserving of the care that we provide and that you support financially and will be providing directly, really need us to pay close attention to that, right, to narrow that gap. And so we talk a lot about time horizon. What's a time horizon relative to effective initiatives? And then providing the opportunity for those initiatives to take place. Something that health insurers typically don't allow to happen. And so that's why entering into different relationships with health insurers is extremely important as well. And so really looking at that aspect of it. And then at the heart of what we do as well as community, right? And that's the 5th strategic priority that Dr. Kuput and his colleagues have set for us, which is engagement with the community. Not just awareness about what we do, but actually gaining additional feedback for them in terms of where are the gaps, how can we best serve, also how do we partner, because we can't do this alone. And so we have a lot of partnerships, but the board has charged us to increase those partnerships even further to be able to leverage in. We're not going to solve food insecurity for our patient population, but the Central Texas Food Bank does an outstanding job. So how do we strengthen access to those resources? And we're already making investments into that this current year as it relates to being able to do closed loop referrals, which will start happening electronically later this year in October. So some very exciting things that are occurring there as a whole. Was jotting some of the questions that you have down. Dr. Kuput, anything to add to the strategic priorities from your end, sir?
No.
Okay. So issues on Horizon, I touched on it. I think that probably, and Tom may be a little bit tired of this one, but workforce, right? We're really looking at, and it's not just compensation, right? It's the environment, it's supportive, it's recognizing that folks have been exhausted the last 2 years. Community care, like so many other healthcare providers, really ran hard, fast, did a lot within the community to help mitigate the adverse impacts of the pandemic, which is still present. Hopefully not to the same intensity as we move into the fall, but if it does, we stand ready to step forward and up like we have before. But recognizing that, how do we create environments then that our employees are feeling like they're able to actively contribute not only to the patient's outcomes, but to their outcomes. So striking a better balance between work-life balance is extremely important, and we've committed some resources to that as well. Drawing in additional resources. So the need's great. When we talk about 125,000 plus unique individuals, non-COVID numbers, that's probably 140,000. That number is down than what we would have expected because of COVID. So with that stated, when we take a look, for example, on our mental health side, the behavioral health side, we're doing a great job. There's still a lot of gaps, as your report demonstrates on the primary care side, but the vast majority of that 125,000 individuals are getting their medical care. About a fifth or so are getting their mental health services, behavioral health services through us. There's opportunities there. There's opportunities to strengthen substance abuse, for which Central Health is already committed this year to help us increase and leverage in those resources. But there's opportunities there, especially as we're seeing increases. Opportunities potentially for us to partner differently with schools, not just simply reflective of yesterday, which was a very tragic event and something that's disturbing to all of us. But thinking about how we partner with schools, because our kids, even more so than prior to COVID, need better mental health support. And so what role do we play as a community provider to help them, either through virtual, on-premise, whatever it may be? To that end, we were very fortunate to receive our first school-based services site award from the federal government recently, and are working with AISD in establishing our first school-based health center, which hopefully will happen later this year. So that's one of the ways that we equitably are looking at approaching the community a little bit differently. Strategic initiatives of support, workforce, you got that. So that comes across in how we contract with you guys, and recognizing that as we've leveraged in additional resources, we're at, from a proportionality perspective, Central Health is actually supporting us at the lowest percentage point ever last year than ever before, which doesn't speak to your support. Your support is tremendous. It's at its highest financial level, but proportionally, it's at its lowest percentage because we've been able to draw in additional resources. So we've been successful at finding those rabbits or gems to help with helping financially, but there's only so many of those opportunities. So we're working with your team about how do we actually leverage in additional resources, inclusive of as we're building additional capacity on the primary care medical Oral health is another one I was remiss in not mentioning. There's opportunities there when we take a look at roughly 25,000 or so adults and kids are coming through for dental services. Again, relative to 110,000 medical, there's still some opportunity there, right? That's why any new site that we have, we're contemplating putting in dental, be that Chalmers, which will come on later this year, Pflugerville, our new health center that will come on thanks to your support and partnership with the owners there in early 2023. We're thinking January, depending on permitting. If you guys can help with that, please do. If you guys have the same struggles, we've talked with Mike and Stephanie, others about that. So hopefully by March, and then of course Del Valley, Austin's Colony, Hornsby Bend, but Del Valley includes dental as well, Hornsby Bend to less extent. Other questions? I kind of going from memory here.
What I'd like to do, and
Yeah.
thank you for Jason, I'm going to go and ask each member, if they have additional questions or comments they'd like to make. The one thing that sort of stood out to me is that I'm on other FQHC boards and everybody seems to be talking about workforce right now. It's very, very difficult to not only keep workforce, but to recruit new workforce. As we bring up our clinical side here in Central Health, is there a synergy? So, if you have qualified individuals that come and apply, but, you may not choose them, but they may be right for clinical services over at community care. Will there be an alignment or some sort of way that we can look at maybe solving not only Central Health's support structure issue, because we will need support as we do that, as we create this practice, but could also help you in being able to find and provide you with providers that could provide a service. And that's just a question.
Yeah, and I think fortunately that structure exists already because when someone applies, they're applying through a collective portal that's shared between Central Health, Community Care, and Sendero. They're applying to specific positions.
Sure.
We've broken it down so when you apply for a medical assistant position, you're no longer applying just to one site. Essentially, you're in the mix for everything. So because we have both community care, HR, and enterprise functions, that should be very easy for us to go ahead and contemplate making that even easier for candidates and identifying candidates. At the same time, we need to be respectful of, if a candidate's applying for community care or Central Health,
sure.
How do we make sure that their confidential application is respected?
Sure.
I think that's something we could work through with human resources and as disparate entities working towards the same end. Yeah.
That's great to hear, and I think a great synergy. Mike?
Yes, and just so this board's aware, as I mentioned earlier, that we're working through some HR transitions. In fact, I've got meetings later this week to start looking at how we can capitalize on those synergies. And I owe Jason and Wes a conversation after next week to say, all right, this is what we're thinking that it could look like. But I feel safe in saying that that's exactly the direction that we're headed in.
Thank you. And you don't have to go into a lot of detail here because I think we're going to take it up at another time. But I know there's a synergy with Medicaid clients being sort of directed to community care. And I got to be careful about that word because Medicaid doesn't like you to direct anything to anywhere. But in essence, is there a possible synergy between Sendero having a Medicaid program or administering a Medicaid program and a value that is to community care?
So unequivocally, yes. As with any health insurer, we always look to leverage in partnerships that advantage our patients and the populations we're serving. And having a enterprise partner that is in a space for where we have upon tens of thousands of patients now. 48,000 to 50,000 of our patients are Medicaid based. mostly pediatric, CHIP, Parent Aid, but we do have Star Plus as well, adults in that. And so to my earlier comment about time horizon
Right.
and longitudinal approaches,
Right.
those are things that an enterprise partner could help us in a different type of contractual relationship. Yet, should they be receptive to it, be able to advantage the community that much more. It's no different than how we would approach it with some of the other insurers, but simply working closely with an enterprise partner who has a Medicaid product would be advantageous.
Thank you very much. I
Of course.
appreciate that. Manager Greenberg, any comments or questions with regard to this dialogue?
I just want to thank you for all of the hard work and for being here with us today for this dialogue. I think it's really important, and I look forward to continuing it, to seeing how we can collaborate closely, particularly with these new facilities. Thank you.
Yeah, thank you, Manager Greenberg. I appreciate that.
Thank you, Manager Greenberg. Managers Moore?
No questions.
Thank you. Manager Valadez?
When we opened up the Southeast Health and Wellness Center, one of the things that I wanted to see is that serve as a base for pulling offices, doctors, therapists, et cetera, grocery stores, pharmacies, down to the Southeast quadrant and out, because we knew that that's where the affordability question was pushing people out of Austin, out into the perimeters of Travis County, and forcing them into other counties that don't have the same resources that Travis County has available to them, to the residents. And so I think that the perfect partnership in our enterprise tied to integral care and tied to the 17 school districts that exist within Travis County, starting from the time the child enters the school system until the time they pass away, is perfect, because with expanded Star Plus, with expanded, which could take your child to time of death, depending on if you were entering into any of the Medicaid waiver programs, would allow you all that ability to expand services to things that you're not even contemplating or thinking about right now, because maybe you haven't received patients that live in that world. But for those of us as parents of those kids that are adults, that have grown to adulthood, that are in that world, there's so much more that could be done. The coordination of case management, the nursing and medical care, the specialty care and primary care that could be offered to them, the mental health care, the psychiatrists, psychologists that is necessary for the behaviors that are exhibited oftentimes by our family members that live in that area. There's so much, and growth of the new programming with ability to share your, I don't know if it's possible, share your employees, share the responsibilities and the case management component. I see a lot of things possible if we can work as a partnership with all those entities that contributed to the quality of life for those patients. And I'm excited about having that conversation with you, and with thinking about things that we have not yet really breached or broached here at Central Health with respect to the full environment of what we offer our residents in Travis County and beyond.
I think that's very well stated, Manager Valadez. I think our role is to, wherever feasible, remove barriers that confront our patients, the communities we serve, and across all lifespans and across all complexity.
That's
and
right.
We can't do it without you guys by any means. We can't do it without other partners. And that's one of the things that's exciting about, where Central Health is heading and how we partner to develop a broader ecosystem that better supports the safety net population here in Travis County. So
I just want to say one
Of course.
one quick thing one more time, that with school districts, it's not only the expansion of services to the individual students and their families, but I'm talking about the provision of curriculums that will allow us to grow workforce, employees that will come and provide those services in a any number of ways. And, I thought that when UT came to town and AISD, we were pushing for the AISD alignment of, you grow your own health providers, and you grow your own teachers, and you grow your own this, and you grow your own that. This was the perfect way to do it. It hasn't quite worked out that way. But because there's transitions within our school districts, and because the school district trustees know that they have failed to provide so many services to our population, especially our special needs population, they've failed TEA standards 4 years in a row. This would be an opportunity to leverage that with different school districts in saying, let's help you develop that curriculum, and let's work together to provide opportunities for us to hire your graduates, as CHWs, as medical providers, as this, that, and the other. So thank you.
Well, I think you're going to be very excited to learn some of the initiatives that we have around this. That's part of our workforce initiatives, is what you're outlining is how do we more intimately engage with the school districts about going ahead and demonstrating there was a glide path towards good professions within healthcare, and how do we actually support the ability for folks to get the training they need to. So there's a couple of things, thanks to some sort of support from the board that we're working on right now. And hopefully within next year, we'll start yielding some real results.
I appreciate it. And I appreciate you all.
Thank you, Manager Valadez. I'm going to go to Manager Jones and ask him any questions or comments you'd like to make. I like to keep you guys on your toes, because if I keep going the same way, Yeah, I am.
Stay awake.
No, I concur with my colleagues, and thank you for the work you've done and the support you have. I'd just like to get a clear understanding. Earlier, you talked about the delta, or the difference, I should say, between what we're funding, what our support is now versus what it has been over time. Could you sort of help me understand that again? Because I'm wondering, one, is that inflationary difference, or are there other factors that are going in to make that difference?
No, I think it's just inherent growth. So the difference is, like, if we go back to 2009, when the City of Austin clinics rolled into community care to operate, the funding level through Central Health was over 60% of our overall budget, may have been 62, 63%. And then over time, as we've continued to grow as an entity, at that point in time, we were serving 55,000 unique individuals, roughly 125,000. And so through some of the acquisitions, Austin Obstetrical and Gynecology, and then Carousel Pediatrics of note, we've been able to go ahead and diversify the payer mix to skew more towards, instead of 60% uninsured, now it's 47%, 48%. And so with that additional revenue and means that comes through a more diversified payer mix, relative to our overall budget, the percentage of Central Health's contribution to that budget is lower. But the total dollar amount is higher. And I want to be clear that we don't do what we do without you guys, and the investment that you make is at the highest level, especially considering district as part of that equation.
Okay, thanks very much. That's very helpful.
Of course.
Conversely, then, if indeed the payer mix has been brought in from other sources, are those sources the population to which we are to serve?
We are as a health center.
Right, but not
you as a statutory underneath section, as a healthcare district, you have a different charge. But as a community health center, yes, the expectation is all patients, all individuals who are uninsured or underinsured that have incomes less than 200% within our service area are expected to be served.
Right, but I'm just wondering, when we look at the population as a whole, of those who are needed, as you've reached adequately and successfully so to get other payer mix to come in, has there been a disproportionate burden or lack of access to populations who could have been brought in because of your desire to meet the business needs of that?
Not at all. To the contrary, if you take a look, our adult population averages 69% uninsured. Our adult population last year was 74,000. So we're at a higher level than we were in 2009 of uninsured individuals in totality. and especially as it relates to Travis County individuals as a whole. So if we showed a graph, you'd be able to see that there has been no erosion of services to Travis County residents who are uninsured. In fact, it's the opposite, it's increased. We've leveraged in those resources to create more robust systems around those patients, sir.
Okay, then. Well, thanks so much. I would like to offline talk with you about that because I know with the drastic demographics change in Travis County and the impact it is having on surrounding counties, are we as a district doing what we're supposed to be doing to address those, or are we deferring that to our partners to do that on our behalf? And that's a question I still don't have quite a clear understanding of.
Sure, and we could take that offline, Manager Jones, but I think just very briefly, I think what I see with your new equity-focused strategic delivery plan is Central Health engaging even more fully into what the population's needs. And as a very large funder of care and soon to be entering into direct provision of care, that only strengthens the safety net as a whole. So that to me just means that our patient population and the underserved communities are much better served. And they have been. When I compare to other uninsured populations that I've had the privilege of serving over the years, being in Chicago or the Twin Cities, the resources that are available in this community far outpace those other communities.
Well, okay, we'll discuss all that. Thank you very
no,
much.
of course.
Appreciate
Yeah.
it.
Thank you, Manager Jones. Manager Malkapani.
Thanks. First is going to be around the workforce question, or just the workforce notion, of course. Clearly, the $8 million in money is what makes the biggest difference. And given that, it's pretty, I know it's generally consensual that there are a lot of variables that go into best practices as far as human capital management is concerned. Clearly, you have a good handle on the analytics, knowing where the churn is and how to get over those churn hills. What other sort of, and this may be for you and for Mike, but best practices in human capital sort of leadership are being integrated, understanding that, of course, cash is the integrally most important variable there, but other ones like, I don't know, open communication, safe and comfortable work environment, connection to larger mission of self, maybe inbuilt job training in a world where stackable credentials are there. Any of those that you might be able to share with us?
Yeah, well, you're hitting on some of the most specific and important other initiatives. We know that compensation is important, but it's usually on the list. It's about third or fourth. But as communities become less affordable, it rises, right, in terms of how folks are going ahead and making decisions about where they want to work and how they want to work. But I mean, culture is very important. Do they feel like they have a voice in the processes and in their work? So developing that, expanding upon that. And then also trying to go ahead and we talk a lot about systemness and where appropriate to go ahead and be standardizing our services from site to site so that it becomes more predictable for folks. So if they do have to shuffle or be placed from one site to another, it doesn't feel completely different, right? Which is where we've been in the past. And I want to be clear and forthright that that's a work in progress. It's always an evolution, but that's part of it. And then it's also the wellness balance that we have. We are very, very fortunate that we have a highly engaged employee population. Like from a mission perspective, I mean, folks feel very good about that. And so it's imperative that we figure out how we better support them so they can support our folks.
How's that measured?
Oh, we do an annual survey every year that's consistent with National Health Centers. Yeah. And we've been using it now since, I think, 2012, 13, Dr. Cooper. It's called the Pulse Survey. And so we're able to see year over year results. It's a very thorough average, about 60 to 65% response rate. And it's demonstrated the last 5 years improving results in terms of how we're compensating, but also the environment, a lot of other factors in there. We'd be happy to share that if Mike would like to see it and that he could share it with you guys as he deems appropriate.
Yeah, and I don't want to dig that much further.
Yeah, no
Yeah,
worries.
Just curious and wondering, so in as much as these changes are concerned, would there be, does the enterprise, if you will, or at least community care, have the leadership in human capital to be able to sort of carry all that out over the next 3 years? Or do you feel like that would also be something that's explored and looked at as well?
So we're expanding our leadership, but we're also expanding across the board. We're trying to go ahead and develop leaders from within, but also make sure that they have opportunities for growth, because in that and of that, they end up with greater satisfaction. So doing that as well.
Cool.
So that's all part of it.
The second one, I don't need a response to. Well, just a kind of a yes, no, but it was around the closed loop referrals, and it's something I'm uniquely interested in. I think I've spent a lot of my life working with ingredients that comprise that. Wondering if it's plausible to think that there may be an opportunity for a presentation on where we're headed with that, maybe sometime in the next couple of months, and then I would suggest it if so.
Yes, we can.
Thanks.
Happy to do that.
Thank you, Manager Motwani. Manager Musaiti.
Well, thank you for being here. Thank you, Dr. Cooper. It's great to see you.
And we failed to mention our vice chairperson, Pilar Sanchez, is on. She was able to join virtually as well. Just
You
for
know, I
awareness.
can't see tonight whoever is on, so I apologize.
None of us can see.
So miss seeing everyone. Really, Actually, I'm going to head to a different direction. I wanted to ask and highlighting going back to our health equity strategic plan. And part of it is the prevention, cancer prevention. I think that's something that our community, based on the community engagement and the data that was presented, that we lack, that we need to improve. Our screening rates for breast cancer, cervical cancers, the top cancers. I'm just wondering, what are your plans so you can help us, with our plan here? So what do you have down the pipeline to address this, and especially given the pandemic? And we know that about more than 90% of women did not get their adequate mammography screening during that period of time. So we're probably going to see more cancer diagnosis because of that. So what do you have any plans to address this?
So absolutely. So we've been going, your chief medical officer, who was formerly ours, helped kickstart. Yeah, we still hold that against him, by the way. Just kidding, Dr. Schultz. I know he's behind me. All kidding aside, we kickstarted through his leadership, and now Dr. Yagoda and so many others, evolving care model. And part of it is when we take a look at no missed opportunities. So we have on the breast cancer, cervical cancer screening side, we're in the top decile of cancer screening for community health centers across the country. It's about 70% of our women who are age appropriate, depending on which screening we're talking about, have been screened, but there's still opportunities there. As our director of women's health, Dr. Ashley Shakroon, she set 100% goal there. So what we're doing is within the care model is we're making sure that our care team members, our medical assistants, nurses, are reviewing current status at the time of appointment, prior to appointment, through the pre-registration process. And if they're not, if they haven't received their mammogram, for example, they're empowered to go ahead and schedule that person to increase the rates. Colorectal cancer screening, there's a lot of opportunity there. A short 4 years ago, we were at 18% screened. We're now at 41%, but there's a lot of opportunity there. So we're looking to continue some of the work we did with UT Austin and some grant funding wherein we mail FIT tests or the FOBT tests home and to increase screening, but are also looking at other engagement strategies. One of the opportunities I think we could do much better is to the time horizon comment I made earlier. Healthcare all too often focuses on who's on your roster for the last 12 months. And so within our population health management infrastructure, we're trying to build the analytics to make sure we don't lose sight of those patients so that we can much more proactively engage them. And the first step is to bump that out to a 3-year time period to make sure we're capturing and offering that back up. And thanks to your supportive investment in our implementation of EPIC and investment on our side, we have much more data readily available to be able to engage, and also able to use MyChart within EPIC to reach out to patients much more effectively than we did last year. a year ago, a little bit less than a year, a little bit more than a year ago, Manager Stiefis, we didn't have a patient portal. So.
And also in addition to prevention, cancer survivorship, also with this population, we know many also with underserved population, they suffer many chronic illnesses as well. So just wanted to think, address this issue, and hopefully that you can enhance their survivorship. And I don't know if you collect that data, because I know some FQHCs are having difficulty because many of them, many patients receive care as specialty care, and they come back with all these comorbidities that really overall impact their survivals and quality of life. So in that space, I think other FQHCs are working to improve that cancer survivorship among this population as well.
Yeah, so I think that's a great point. I'll have to go back with our team. I do not think we have anything specific on that. So perhaps I can pick your brain on what you've learned in
I'm
other
working with Harris
conversations.
Health, so I know.
With who? Oh, Harris. Okay, perfect.
So in that space. So
Yeah,
again, I
that'd be
would
great.
like to know our rates in terms of cancer diagnosis, past diagnoses.
Sounds good.
So we can work around that. Thank you so much. I really appreciate you.
Thank you, Manager Scientific. Manager Brinson.
No questions. Thank you. Very interesting.
Thank you, Dr. Brinson.
Thank you very much, Jason and Dr. Coopwood. I got a lot out of this dialogue. I thought that this exchange probably needs to happen maybe twice a year, or definitely once a year, but twice a year would be nice. And we support community care, as you know, and we support your mission. And so the more we can understand where the synergies are and how we can utilize those synergies to make the enterprise more effective and more efficient, I think is probably the goal here. So thank you for your time. Thank you for your dialogue and information, and we look forward to talking again soon.
Well, thank you so much for the opportunity and all of your support.
Yeah, thank you. And I think that working together more closely, I think, is going to happen now that we have these both your strategic plan and ours mesh real well. And I think we do need to have more interaction at the board level. I know the staff level is, they're fixed at the hips, but we don't, as our boards don't, are not as well coordinated. So maybe we can look into that too, Dr. Bell.
Thank you, Dr. Cooper.
Thank you.
Appreciate
Bye-bye.
it. Mike, did you have any comment? Manager Motwani?
Yeah, I did. In a similar vein as Dr. Coopwood shared, it did occur to me during this conversation, and I thought it worthy of mention, how nice it is to have two strategic plans that share a North Star, and we can see kind of how those constellations overlap. It's very, very helpful, and kudos all around to leadership teams, staff implementers, and everyone who's had the vision to help us get closer and closer. Thanks.
Thank you, Manager Motwani.
30 seconds.
Yes.
So that has been my request for a long time. I would like to see our enterprise leadership working together and talking like this as to what we can do with our staff, supporting the strategic alignment issues that they're addressing behind the scenes to bring to us. We don't get to hear everything that they're doing, but if we have a common vision, which we all do, and tie that in with Sendero as a provider of connecting the clients to the services. And if we can get this Medicaid Star Plus program going, that's my hope for getting the entire population aligned. Our missions, I know, are aligned, but to get all the services and the wraparound services and the supports coordinated with other governmental entities, that would be great. We might then be able to see us coming closer to ending those disparities gaps and more efficiently using our tax dollars. Thank you.
Thank you so much.
Cynthia, just to build on that a little bit, I've kind of wanted to have a community group to take care, to help
That's right.
with the social determinants of health or the political determinants of health, because Jason mentioned a few, but there's housing and sidewalks
that's
and
right.
lighting and all these kind of things, and working together as a community would
Yes, sir.
make a big difference.
You're exactly right.
Healthcare wise.
Like our little conversation sitting next to each other at Central Health, where we talk
Yeah.
about the stuff that's not being brought up. Yeah, that's exactly right. Thank you.
Thank you, Dr. Cooper. Appreciate it. Thank you both. Okay, members, agenda item number 3 is to confirm the next regular executive committee meeting date, time, and location. Managers, our next Central Health Executive Committee meeting is tentatively scheduled for Wednesday, June the 15th at 5 p.m. at Central Health Headquarters, 1111 East Cesar Chavez Street, Austin, Texas, 78702. At this time, I'm ready to accept a motion for adjournment. I have a motion from Manager Greenberg. I have a second from Manager Valadez. Any discussion? All in favor? Any opposed? We are adjourned. Managers, in the interest of time, I would like to go directly into our board meeting. And so at this time, today remains May 25th, 2022, and it is 6:19 p.m. As a quorum of the board is in attendance, I'd like to call to order the meeting of the Central Health Board of Managers. First item of business.
Well, that's what put me into my little financial crisis was somebody came and offered me, I never intended to move, never in my life was I going to move. But the houses started getting more and more expensive, so taxes have started going. And someone offered me
I should be all clear on.
Okay, we are all clear.
so much money.
You took it.
I took it, but now
I
have to
will
find a place to go.
call to order the Central Health Board meeting. Good evening. Today is May 25th, 2022, and it is 6:21 p.m. As a quorum of the board is in attendance, I'd like to call to order the meeting of the Central Health Board of Managers. First item of business will be the consent agenda. Consent agenda item 1, approve the minutes of the Central Health Board of Managers, April 27, 2022 meeting. Consent agenda number 2, receive the quarterly investment report and ratify Central Health investments for April 2022. Do I have a motion? Manager Valadez.
I move that the board approve consent agenda items numbers C1 and C2.
Do I have a second?
I concur.
I have a motion from Manager Valadez. I have a second from Manager Brinson. Any further discussion? All in favor?
Aye.
Any opposed? Any abstaining? Motion carries. We will now proceed to the regular agenda. At this time, I will entertain a motion to limit debate on all items in the regular agenda for our meeting this evening. Manager Valadez?
I move that the board of managers limit debate on all items on the agenda to 3 minutes per member per item.
Do I have a second?
I second.
I have a second from manager, I have a motion from Manager Valdez, a second from Manager Brinson. Any further discussion? All in favor?
Aye.
Oh, I'm sorry.
So how are we going to maintain that we're keeping to that timeline?
I have a timer that's right over here.
Yep.
Okay, will it
That
go off?
notifies me when, and just so members know, I try to be as flexible as I
I know you
can.
do. I know you do.
And so I don't want to cut off discussion when I think it's productive discussion, but when I feel that the discussion is moving a little bit too far, I have to rein it in just to manage time. So, but my timer is the staff. Okay. Oh, okay.
Sorry to all of us that were chattering.
Hope it wasn't embarrassing, chatter. Okay. So I have a motion on the table. Any further discussion? Hearing none. All in favor?
Aye.
Any opposed? Any abstaining? Motion carries. Managers, because our agenda is very full this evening, we will take up the most pressing matters first to make sure that we get those urgent issues taken care of. Therefore, hearing the first item, we will move to items 6 and 7 in closed session, followed by items 4, 2, 3, 5, and then 8. Just to say, we do have some consultants for our disparity report, and we will try not to keep us here so late that this consultant can't speak to us when we come back into open session. So I ask your indulgence to please keep your discussions as concise as possible so that we can move forward on these agenda items. Thank you. Agenda item number 1, discuss and take appropriate action on the proposed amended mandatory payment rate to be assessed on institutional healthcare providers during fiscal year 2022 under the Local Healthcare Provider Participation Program, parentheses LPPF, close parentheses, in Travis County as required by Texas Health and Safety Code, section 298E.151. Katie Coburn will be presenting.
Good evening, managers. Thank you very much for your time tonight. We have been here with you several times this year already, talking to you about the Local Provider Participation Fund and the rates that we need to amend. If you want to move to the first slide, I'll get right to the point, which is we are coming to you this evening with a recommendation to amend the FY22 Travis County LPPF annual rate up to 4.71%. And we are asking for this amendment to be able to fund intergovernmental transfers with the LPPF funds for the Comprehensive Hospital Increased Reimbursement Program, or CHIRP, Program Year 2 advance payment, which is due in June. IGT is due in June. And for the final uncompensated care payment of the year for demonstration year 11, which will take place later in the very late summer, early fall. If you could move on to the next slide, please. So as a reminder, and the Local Provider Participation Fund is financed with money that is assessed on as a uniform percentage of net patient revenue on Travis County inpatient hospitals. The Board of Managers sets the rate, and then Central Health, as the administrator of the fund, collects the funds, holds them in fiduciary capacity, and completes intergovernmental transfers with the dollars. The use of the funds is limited to legislatively defined purposes of leveraging federal supplemental payments. And Central Health staff collaborate with the hospitals on the uses of the funds. We initially set our rate very low early on in January of this year at 0.82%, because there's a great deal of uncertainty in the supplemental payment program environment right now as we move through the transitions in our 1115 waiver program, as the Medicaid directed payment programs get rolling and off the ground. There's just been a lot of uncertainty that we are addressing, and with the kind of being required to amend our rate as needed to meet that. So in January, we initially set the rate at 0.82. In March, we came back to you and increased that rate to 2.36%. And if you'll move on to the next slide, please. We'd like to come to you tonight to increase it further to 4.71%. And you can see in this chart just kind of a history of where we've been. Again, the rate increase tonight is an additional 2.35% for an annual total of 4.71. The annual revenue the 4.71 will bring in is 164 million. Now, what providers have paid in for the previous rates in the past will count towards that. So with this rate increase, we'll be collecting about $81.8 million in additional funds to support the fully funding of the supplemental payment programs available in the next couple months. These are the two remaining funding programs that the LPPF will need to IGT for that we know about right now for this year. We never say never with the LPPF, so it's possible we may need to come back to you again this year for another rate amendment. At this time, this will fund us out for the year. And with that, I will close and take questions.
Thank you very much, Katie. Appreciate that. Any members have any questions for Katie with regard to the LPPF rate? Manager Valdez.
I have no question, Katie. I just wanted to know if I have no questions, Katie. I just would like to know if Dr. Bell will entertain a motion.
I will entertain a motion.
Okay. I move that the board amend the FY LPPF fund, which is local provider participation fund, mandatory payment rate as recommended by staff to 4.71%.
And do I have a second?
Second.
I have a motion from Manager Valadez. I have a second from Manager Zamora. Any further discussion? Hearing none. All in favor?
Aye.
Aye. Any opposed? Any abstaining? Motion carries. Thank you very much, Katie. We appreciate that. And as usual, we appreciate all your hard work that you do to, keep this LPPF fund moving along. Thank you.
Thank you very much.
Okay, members. The next two items are agenda item number 6, receive and discuss updates on the 1115 Medicaid waiver delivery system reform incentive payment, DSRIP program and associated projects, the Community Care Collaborative and other healthcare delivery partners, programs, projects, and arrangements, including agreements with Ascension, Texas and the University of Texas at Austin. And agenda item number 7, consider and take appropriate action on a request from the board of the Sendero Health Plans Incorporated to submit a proposal in response to a Texas Health and Human Service Commission request for proposal related to the Medicaid program. At this time, I announce that the board is convening in closed session to discuss agenda items 6 under the Texas Government Code, section 551.071, consultation with attorney, and item 7 under Texas Government Code, section 551.085, governing board of certain providers of healthcare services. It'll be a few minutes, members, and we will be in closed session. Those who are attending closed session virtually, you should have a link. You need to log out of the open session and go into closed session. Thank you very much.
Microphone. We are getting no signal here in the control room from your microphone.
Do I have to repeat what I said? Okay. We are out of closed session. It is 8:05 and May the 25th, 2022. We covered in closed session agenda items 6 and 7. There were no motions required on either of those agenda items. Members, because we have a consultant who will be discussing agenda item number 2, I will move that agenda item up and take it next. Agenda item number 2, receive and discuss a presentation on historically underutilized business program work updates and the Central Health Hub Disparity Study. Mrs. Colette Holt from Colette Holt and Associates will be presenting. And let me just say, Ms. Holt, we apologize for the lateness of this item, and we do appreciate your indulgence and patience in working with us.
And real quickly, if I may, Dr. Bell introduced Colette Holt. Let me just make sure
Sure.
she's on. This is Lisa Owens. So as you recall, in November 2020, we engaged Colette Holt and Associates, a national law and consulting firm that specializes in issues related to minority women and disadvantaged business enterprise programs. They have completed our disparity study, which we have shared with you. And CHA, Colette Holt and Associates, is led by Colette Holt. She's the founding principal, and she's a nationally recognized attorney and expert. Again, I'd like to echo the appreciation for the late hour, and I will turn it over to Colette to give you your presentation.
If you could remind those presenting to check the mute on your microphones, please. If you'll stand by, we'll make sure that you're not muted on our end. So pause just a moment if you are speaking. Thank you.
Well, oh, okay. Hello, sorry. I went away from my desk here to try and get something else done. So I just got Lisa's text. So I guess we just get started here. You guys tell me. I'm sorry, I stepped away for a couple of hours here, so I'm not quite sure where y'all are.
Yes, Ms. Holt, you've already been introduced. And so if you can just provide us with the presentation, that would be great. And again, thank you for your patience and for staying with us throughout this late hour.
No, no worries at all. It's absolutely fine. Someone else is going to run the slide. So how about next slide, please? Okay. So what were the disparity study objectives? First is to provide a legal defense if your new programs are challenged, to meet the constitutional requirements that the courts have imposed on race and gender-based programs. Most of you probably know that the federal courts are extremely hostile. Oh, sorry, but I think the cat hasn't had dinner yet, so he'll just have to wait a minute. That the federal courts are extremely hostile to any type of race or gender-based program. And it's important that we stay within the parameters that have been given to us to comply with 14th Amendment requirements. We also like to use the study to provide policy and program recommendations, especially for an agency like yours that has not really had what we would probably call a true formal MWBE program. And lastly, we try to write the study in halfway plain English so that we can educate policymakers, stakeholders, the community about what the legal standards are and the economic approaches that we used to build consensus for your new program. Next slide, please. So you can see here the data and methods that we used. The quantitative data, we had many sources. For qualitative data, we also did interviews, and we also included the anecdotal information that we have collected from our numerous other Texas disparity studies. Next slide, please. So here are the elements in the study, pretty much just follows along with the table of contents. So you can see there, we do have a legal review. We had utilization, availability, and disparity analysis of your contract data. We included an economy-wide disparity analysis, as well as anecdotal data, and finally, recommendations. Next slide, please. So we analyzed 6 years worth of contracts, which is actually a lot for a study. So we feel that we have a good solid basis and that we don't have any years that are particular outliers. So our final contract data file contained 103 prime contracts, and we had 79 associated subcontracts. And of course, lots and lots of detail is provided in the actual report. The federal courts tell us that a local agency can only remedy discrimination in its own contracting marketplace. And it turned out that Travis and Williamson counties captured almost 85% of the dollars that were spent in the state of Texas. So we limited our analysis of firms that were available to do the type of work that you procure in those counties. And the type of work that you do procure turned out to be 55 in industry codes, and NAICS stands for North American Industry Classification System, which is the coding system that the Census Bureau uses, as well as certification agencies. And again, we provide more detail on what those codes are specifically in the study report. Next slide, please. So what was your utilization of minority and women firms on those 103 contracts? You really did, I think, remarkably well for an agency that has not really had a true formal program in the sense that we usually mean it. With the vast majority of those dollars going to firms owned by white women. But still, that is really pretty exemplary when you haven't been using all of the possible tools that would be available to you under an MWBE program. Next slide, please. So that's your utilization. That's who received your funds, primes and subcontractors. But we also needed to determine what was the availability of ready, willing, and able firms in your marketplace to provide the types of goods and services that you purchase. So you see that overall, minorities and women make up about, let's call it 14% of the available firms in your market. And you see that broken out for the various racial and ethnic groups and for white women. What I mean by weighted availability is an availability analysis that reflects the weights of your actual spending. If you just count heads, which is the first step, of course, you can get some very odd results. And so the courts have told us that your availability analysis, at least at the level of overall goals, needs to reflect the weights of particular types of spending in which you engage. Next slide, please. So we have utilization and we have availability. So now we can, in fact, run disparity testing. And there's some fancy looking equations, but it's really a very simple idea. And that is, how tight is the fit between the firms that were utilized and the firms that were available. To the extent that there's a big gap, that can be evidence of discrimination. So you see there, actually, your utilization of MWBEs is above parity, because parity would be 100%. And so you really did overall quite well. We did test these results for both statistical significance and what's called substantive significance, which looks at how large the gap is. And again, we actually have an appendix to the study that goes into some depth about what these terms actually mean. But I think the short way to think about it is, how likely is it that these results are from chance, and how big is the gap? And you see there that some of the results were significant, as well as substantively significant, as well as statistically significant. Next slide, please. So one of the things that we wanted to look at, because we were a little surprised to see these very high ratios, was whether or not those outcomes were evenly distributed amongst the various MBE and WBE categories, as well as amongst the various types of codes and industries that you use. So it's both a vector on firms and then taking a look at the codes. And so we looked at codes whose weight was at least 6% of your overall spend, so that it would be something of some substance, and where utilization exceeded 6%, so we could focus on the most important codes. It is in fact possible to do this straight out of the tables, but we thought that we would provide that as an easier reference. And one of the things that we see is that the NAICS code share of spending in these most important codes was much more important to MWBEs than non-MWBEs. And that reliance ranged from twice as important to almost 40 times as important. And so what we take from that is that MWBEs are much more concentrated in a small set of codes than non-MWBEs, excuse me. And I think that has some implications for where you might want to focus your energies going forward in the future. Next slide, please. So that's the analysis of your own contracting records. We also provided an economy-wide analysis, and this is important because it gives us somewhat of a take on how effective just a fully race and gender neutral program is likely to be as you expand out the types of services that you provide to your community. It's our understanding, and obviously someone correct me if I'm wrong, but that Central Health is embarking on a significant building program to be able to begin to provide more direct services to the Austin community. And that will change the face of your contracting profile. So we wanted to take a look at what happens in the wider economy where affirmative action, contracting, supplier diversity type programs really are not practiced. And we looked at two Census Bureau databases for this. The first is the American Community Survey, which looks at the experiences of actual individual entrepreneurs. And there we saw that minorities and white women form fewer businesses than white males and earn less from their businesses than their comparably situated white male counterparts. We also looked at the annual business survey, which looks at firms. So ACS is people, ABS is businesses. And there we saw very large disparities in the sales receipts between minority and women-owned firms and comparable non-MWBEs. We also examined what is now really quite extensive government and academic literature on barriers to equal access to business capital on the basis of race and gender. And those research papers definitely support the conclusion that minority and women-owned firms, especially Black-owned firms, do not enjoy equal access to accessing credit with which to run their businesses. And then last, we did look at some human capital constraint data, which will, of course, impact the ability of minority firms to grow and to be successful. Next slide, please. So we really did target our interviews for you because we've done so much work in the Texas area on firms, individuals that had a real interest in your types of contracting. And the minority firms that we interviewed said that they still suffer from negative perceptions and stereotypes about their competencies and their qualifications. Everything you see here is really, sad to say, really, squarely in line with what we hear everywhere across Texas and really, frankly, across the country. Some women definitely continue to experience gender bias. Minority women often suggested that race was a bigger barrier than gender to their opportunities. I thought that was interesting for you. There was a real stress on the commitment of senior leadership to making sure that opportunities to compete are equally available to all. Some interviewees did suggest that obtaining information about Central Health's opportunities, solicitations can be difficult, and they wanted more outreach. But several people did laud your agency about their positive experiences with procurement and contracting, and suggested that you keep doing what you're doing. So that was some very positive feedback. Again, we did also include the anecdotal data from our other studies that really talk about the same things about racial and gender biases in the business community. Next slide, please. So now turning to our recommendations, we divided those into two types. The first overall type or bucket is race and gender neutral ideas about contracting enhancements that will help all firms, especially small firms, and MWBEs, of course, tend to be small, to do business with you on a race and gender neutral basis. We certainly recommend getting an electronic data collection system. This is just a critical foundation to running a good program, is collecting data, monitoring what your vendors are doing to make sure they are complying with the program and their contractual commitments, and letting MWBEs and small firms know about what opportunities might be available to them. We're suggesting creation of some type of an Office of Business Diversity. There are different potential ways that could be structured, but we do think it's important that there be someone whose job it is to make sure that these new enhancements get done, and to be able to be the point person to be transparent with the community about what Central Health is achieving. Certainly more vendor communication and outreach, and the notification system is a big part of that, so that everyone knows about you. I think you're kind of a well-kept secret in some quarters, so time to get that word out. And then we also suggested partnering with some other local agencies and organizations to provide technical assistance, bonding, and financing type of programs. No need to reinvent the wheel. Many of the firms that would do business with you are also doing business with, for example, Travis County or the city of Austin or Capital Metro or whatever. And so working with those agencies, I think, is something that people will be very interested in. And I know that both the city and the county are certainly interested in working with you. Next slide, please. So turning now to the race and gender-based recommendations, we are certainly suggesting that you adopt a formal minority and woman-owned business enterprise program. Use the study to set your goals, both your annual goals and contract goals. It is important that you set your contract goals on a narrowly tailored basis based on the scopes of work of the project, the availability of MWBEs to perform those scopes, your progress towards meeting your annual goals, and any other marketplace factors. It's important that you only include firms in your program that have suffered discrimination in your marketplace. I would very much urge you not to try to do your own certifications. It is extremely resource intensive to do it correctly and up to standards. And frankly, it's burdensome on the MWBEs to have to go from agency to agency to agency getting certified. So we can talk perhaps at a later date about what programs meet those standards. You certainly need to employ rigorous compliance and monitoring procedures, policies to ensure integrity in your program. And you will need to provide training to your own staff and vendors on any new initiatives. been kind of a long day. This afternoon, I did a training for Port Houston, which has also recently adopted a brand new program. They've never had an MWB program before either. We did a hour and a half training for their vendors on the new program. So that's something you probably will want to do as well. Then the last two suggestions are to develop some performance standards. It's important that an agency decide how it wants to measure success. There are obvious possibilities like, are you meeting your annual goals? That's very important. But again, given the performance of MWBEs and the patterns that we saw, you may want to, for example, examine whether or not you are getting new firms into your program, whether minority and women firms are doing new kinds of work, whether that work is being spread around amongst firms. So there are different metrics you could use, but I do think it's worth thinking that through, especially as you are adopting a new program. And then finally, the courts do require that you have a sunset date for the program, which really just means engage in a regular program review. Your program doesn't have to go away by a date certain, but you do need a date certain by which you will examine whether or not you need to continue to use MWBE contract goals. The federal courts are very concerned about whether these programs are going to go on too long. So this is an important element to establish a legal defense for any new program you choose to enact. And I believe that is my last slide. That's right. Yes, for which they're duly grateful, given the lateness of the hour. Didn't want to take up any more time than absolutely necessary for you, but I am delighted to answer any questions that you have.
Thank you very much, Ms. Holt. And I'll just sort of go around the dais here and see if they have questions for you, if you don't mind.
No, of course, I'm at your disposal.
Manager Greenberg.
No, thank you. Very thorough, and I appreciate all the data. I do concur with not establishing yet another entity with which, people have to be certified. Yes. And also having a point person. I thought those were really good recommendations and good data, and thank you for your work.
Thank you, Manager Greenberg. Manager Jones.
No, thanks very much. I think it was very informative. It's interesting, some of the challenges that we are facing or have been able to achieve in terms of trying to address this. And so this is very helpful as we go forth to try and to be equitable in our community. So thanks so very much for your time and your information.
Well, thank you.
Thank you, Manager Jones. Manager Zamora?
No questions.
No questions. Manager Matwani?
Thank you, Chair. I thought this presentation was fantastic. Thank you so much. In the presentation, you'd mentioned how a lot of the minority and women-owned businesses were concentrated in certain NAICS codes, and wondering if you saw any unique, and looking at the full report, really appreciate the breakdown. Wondering if you saw any low-hanging areas of opportunity where we may have sort of maxed out in one code area possibly, but maybe not fully maxed, where there may be some codes where there's just not opportunity available for us, and that's a larger societal question. There may be some codes where we may have maxed out what our opportunity is. There may be some codes that are showing us that, hey, there's a lot of opportunity here for us to explore more. Did you see anything like that? Maybe
well, I did. And I think one way to think about it is to take a look at the utilization in each one of those 50 some whatever codes, and then look at the availability and see where there seem to be big gaps. Now, the thing to keep in mind about that is that your contracting profile, at least my understanding, is likely to change going forward. And so while you may have done very well, for example, in things like community engagement or outreach or PR materials, as you start building, that's going to look different. And I do think that you have some opportunities there to really engage with new contractors. Healthcare organizations are a challenge. We just finished Harris Health's study, you know, and of course they're a major service provider. And construction is a place where, at least in the Austin community overall, the other agencies have done very well. Travis County and the city have been able to effectively utilize MWBEs. So I guess I would suggest for whoever is going to come in and take the new spot that will be responsible for this, to sit down and do some planning, to take a look at where you think you're going to be, you know, what contracts you think you're going to be issuing in the next 6, 12, 18 months out. And certainly Lisa and Monica, I know, are very qualified to do that. And then figure out where you want to put your resources and what outreach you may want to do. If you know, for example, that you're going to be designing 2 or 3 facilities, then now would be the time to start doing outreach to MWB design firms. Get those lists, invite them to come down, learn about how to do business with you. Because I can say this as somebody who's worked for probably over 200 governments in my time, and I'm a government contracts lawyer. Everybody's different. And so information about how to specifically do business with you, I think that's where your low-hanging fruit is. But you can certainly take a look at the tables and what you're going to be doing going forward to make some concrete plans about how you're going to increase opportunities.
Thanks. And in your work in this arena, clearly you're working with different public institutions. Is there a way, or have you seen any avenue for this kind of data that you're working with providers like Harris Health, entities like ourselves, where it all gets rolled up to inform other perhaps equity-minded heads of workforce organizations, in as much as, you know, where efforts could be invested to fill opportunity gaps? Do you see that ever happening?
I haven't seen it. I've been thinking for the last couple of years, I need to write a book because we probably have more data than anybody in the country does about all of this. So if I can ever get some time to do it, because we do definitely see trends across the country. You know, I did a presentation, it's been a very long day, for the Nevada Department of Transportation today. Now that's a very different entity in a very different market. And we heard the same things. We heard the same things. So I think we know what helps. It is that kind of bonding and financing and technical assistance. It's opening up your contracts. It's trying to unbundle them. It's making sure people know about you. But there are no easy answers here. You know, I mean, we're looking at well, decades, centuries really, of entrenched systemic racism, for, you know, to just call it what it is, and gender bias. And so that isn't going to go away easily. But the Austin community has always been very committed. So I think you're in a good spot. The city of Austin was my very first client when I opened my law firm in 1994. So, you know, you've got committed people and you've got committed firms. So you're in a lot better place than some of my clients. Try talking to the Oklahoma Department of Transportation about this.
Oh, I know Oklahoma well.
Thank you so much.
Thank you very much. Manager Valadez.
Yes, I actually sent 3 questions, not including the one that I've spoken to you about earlier. One of them is asking whether or not you could provide to us a detailed list of the contracts. You know, that $45.5 million that you talked to us about, that you looked at, that's on page 4, and along with the breakout of the distribution of contracts by race and gender. Is that possible? That was on page 7. So
no, absolutely. We got that list of contracts from you all.
I figured you did. Yeah.
Very well. Yeah, I mean, they're your contracts, so we got them from you,
right.
and we can absolutely, if you want, we can send you the entire contract data file that will have every firm will have a race and sex assignment, as well as a 6-digit NAICS code. Just know when you read that, that spreadsheet, that a firm will be in there possibly with more than one NAICS code. The race and the gender remain the same, but many firms do more than one thing. So just know that, like, if you see like a firm that you are, you might do PR and you do community engagement. So you might have a couple codes, but absolutely, we're happy to send you all the final contract data file. It's yours. You pay for it. It belongs to you.
And when you were outlining the contracts, did you just look at Central Health, or did you also look at Community Care and Sendero, which are part of our enterprise?
Well, now that is a good question. And maybe we should, maybe I need to ask Lisa or Monica, because we got the contract data file and we called it all central health, but there may have been some sub departments or whatever that were in the contract data file. So I'm not sure, but we can absolutely get you an answer to that.
They're distinct entities, but they're part of our enterprise under our umbrella.
Oh, okay. Then no, if they didn't, do they do their own separate contracting? Do they issue their own contracts?
Yes, and the data file is central health only.
Okay, all right.
Contract.
Okay.
Yeah.
I
So
knew
it's
Lisa
not
would
community
know.
care, it's not Sendero.
No, it was central health only.
Was there a reason for that?
I can respond to that. The engagement was for Central Health proper because we were wanting to see, were there some legal avenues that we could go down and pursue procurement differently for just Central Health proper. So this was specific just to this organization by design. And without the other boards, and certainly Community Care and Sendero can contract out to do a similar disparity study.
I understand that, Mike, but we're an enterprise, and just for future purposes, if I would suggest, if we're going to do a disparity study, let's do it for our entity, for our enterprise. That's just my idea. Let's kill 3 birds with 1 stone, and that way there is no each entity having to pay. They can pay their portion, depending on what that would be. But that's an opportunity I think we missed. Thank you very much. And a last question. When you recommend the weighted availability at 14%, could be the aspirational goal for an MWBE program. Do you think that 14% moves the disparity ratio and the WMBE distribution of dollars?
Well, no, it doesn't change the ratio. I mean, the ratio is what it is. It's established by looking backwards. Certainly, I would urge you to make that sort of the minimum overall aspirational goal for the organization. But again, as your contracting profile is going to change, I wouldn't necessarily put that much weight on that, because the availability of MWBEs in the Austin community in construction is relatively good. We're just about to finish the city study. We found pretty good availability in Travis County. So my advice would be to focus on the contract goals, because that's where firms live and die. They want to know about a specific solicitation. They don't really care about some overall thing you think you're doing. They want to know, can I get work on this contract, be hired, and get paid? And so I would focus on that. And I think going forward, you've got some good opportunities for that. Having said that, we have to recognize that healthcare, direct services can be very specialized. If this is what the doctors want, this is what the doctors want, and that's what you're going to do. Pharmaceuticals is a huge piece of spend, and there's really almost nothing you can do with that. There are no minority-owned equivalent of Eli Lilly, for example. So just kind of recognize that. We're about to finish the study for Cook County Health and Hospital Systems, which I think might be the largest in the country. And they've been able in Chicago to get around 18–19%. But just recognize that that's a very different demographic than you have in the Austin community.
I appreciate that. And just real quickly.
Mike, please.
One more. Mike. Oh, I'm sorry. And Colette, just as briefly as you can, explain to me again, why is it that we can separate out or disaggregate the white male from the white female, but we don't do that for the black, brown, Asian females from the female population. So all of it gets thrown in with the women, but it's not disaggregated as like the white males and white women are.
Well, a couple
of reasons. I really am having a difficult time trying to wrap my head around that.
Well, I think there are a couple
it's
reasons.
Almost
part of what I think we're trying to ask ourselves is, what is the experience of minority and women firms compared to white men? Because they have always had the access, the contracts, the power, the control. So that's really what you're looking at, sort of like the null hypothesis for people to go and want to remember going back to those painful classes. And so the data sources that we use generally do include those of us who are minority women in the minority category, because we can't double count us. So we have one firm and we can't just necessarily split us. So we have to make some decisions about what to do about that. I think the other thing to keep in mind, especially when you look at the availability figures, is even if we were to make what I know to be a false assumption, which is that half of the Black firms are owned by women. We know that's actually probably not true, but let's assume that because we don't know what the proportion would be, that you're going to get some very, very low numbers. And our statistician tries to get a corpus of data big enough so that he can manipulate it, because that's what the federal courts are looking for, is statistical significance. We have this problem with Native Americans all the time. So it just seems like we made a decision a long time ago that seemed to be the better way to go. And as you and I talked about a little bit, my advice is to allow minority women to be counted towards either goal if you have two goals. That seems to be a way to give us a little bit, well, an advantage is wrong. I guess I would describe it as reducing the double disadvantage under which we labor.
Yeah, it is a double disadvantage for minority women. Because we're not always, we're having to compete with the minority males. But thank you. I do appreciate that. And would it be okay for us to ask the question, are you a minority women-owned business?
Oh, you mean in your register? Oh, absolutely. And the B2G now system that I think
as Central Health, yes.
Yeah, and the system, the certification data is there. You can't get it off the public websites, but you as the owner of that information will absolutely be able to go in there and see that.
I appreciate it. Thank you very much. Thank you, Colette.
Thank you, Manager Valdez. Manager Musaite.
Thank you so much for that presentation. I don't have any questions. My comment is, you mentioned that not many people know about us, Central Health. So I was wondering if you had any ideas, how can we market our name? I know our marketing team is doing an incredible job, but from your perspective, what do you think would help?
Well, I think maybe going to the city and some of the other local organizations and making sure that you're included in their outreach events. The city puts on lots of events, so does Travis County, Capital Metro, and kind of getting into that mix, which is why you have to have a person who's going to be responsible for this, because we can't just dump this on Lisa and somebody else and say, oh, add this on top of everything. So if you hire someone, their job is to get out there and let people know. Go to the MWB organizational meetings. Austin has a lot of groups, making sure that people get the notifications from you. So you do need an outreach plan. You can't just be haphazard about it. And I think whoever you hire should be tasked with developing that as one of the very first orders of business.
Thank you so much. Thank you.
Manager Brinson.
No questions. Thank you very much.
Ms. Holt, thank you so much. We really appreciate the presentation, the information, and your patience with us.
No problem. You all are ready to go to dinner, I'm sure. And if I, certainly in the future, if I can help you, I do want to take this opportunity really quickly to say thank you to Lisa and Monica and everybody there. You were wonderful to work with. Just a great client. We're sad to see you go. If we can help you in the future, but you've got great folks, and I think you can go out here and really make a lot of progress. I really do.
Thank you so much. Appreciate that. Lisa, is there anyone else that needs to make any provide any information?
We can't hear you, Lisa. Well, Lisa, we're solving a technical issue here. I'll just jump out there and say we look
That was
forward.
my fault.
Great. Perfect timing.
There you go.
Thank you.
Sorry. I apologize. I just will wrap up. I have a memo in the packet, but we will be back later this summer with our recommendations on policy and program implementation. So we look forward to continuing the conversation.
Thank you. And, Manager Valadez.
I don't know if this is to Lisa, to Mike, or to Colette, but is Holt and Associates?
Mike.
Thank you. Yeah, I don't know who this goes to, Lisa. I don't know if it's you or Colette or to Mike, but have we given any thought to the possibility of asking Colette to help us shape a policy and a plan?
But we
I'll
would
defer
certainly be
to-
delighted to do it. So whatever you all need, we're happy to try to help you.
What's the price tag on that?
Yeah, I'll defer to Monica and Lisa and team in terms of what the scope in the contract is. I think it was for the disparity study, but we would need to, as we bring back these plans, certainly partnering with those that have the demonstrated skill and expertise and missional and cultural alignment is going to be important for us.
Right, and we won't overstress or overtax our staff if we can bring them in and help train
Right.
while they work together.
But also, as Colette had mentioned, working with partners in the city and the county too.
Yes,
I think
that's
there's
right.
a lot of resources there that we haven't
Yeah.
leveraged yet and certainly can.
Absolutely.
Thank you.
Absolutely.
Thank you very much. And thank you again, Lisa, your team, and definitely Ms. Holt. I appreciate that. All right. We will now take agenda item number 4, receive and discuss a presentation on fiscal year FY 2023 budget and financial forecast for subsequent fiscal years, including information on possible property taxes, tax rate increases, possible property tax rates to be assessed. I guess I just always think about my taxes and they're going up. So,
up.
Jeff Knodel and Lisa Owens will be presenting.
Thank you, Dr. Bell. I know we have limited time, so I'm going to go through some of the slides fairly quick. But first of all, I do want to acknowledge we have a new member on our team. You see on the cover page, Kim Johnson, who's our new budget and financial analyst, and she's done a great job stepping in right up front and really helping with the process. So as you heard from the previous presentation, and certainly in this process, the financial team has done an exemplary job in a lot of the areas that, that we're working towards. Next slide, please. So financial forecasting, it's an initial financial tool in our budget process. This is the kickoff of our fiscal year 23 budget process. Don't worry, we have plenty of meetings left to talk through different items and different rates. This really just kicks the process off. The forecasting allows us to make financial estimates to just evaluate long-term trends, policies, revenues, and service levels, and also helps improve our decision-making in the long term, just maintaining fiscal discipline and the delivery of the services that we're responsible to deliver. Specifically, as it relates to central health, the central health financial forecast assists with financial planning of known and unknown risk or events to help mitigate any financial volatility. And we've been doing this for a long time. The format hasn't changed a lot, and I think it's really helped us address certainly known areas that we know were upcoming so we can plan for those, but has also enabled us to develop reserve levels that help us address and deal with any unknown events that occur. Also, as it relates to the central health financial forecast, the financial forecast period is 8 years. So we're looking at fiscal years 2023 through 2030. And again, just to reiterate, the purpose of this is to take a long-term look at our financial picture at a very, very high level and then establish an initial property tax rate that once again is the beginning of our budgeting process. So I'm going to skip over the next couple slides. These are board objectives that the board recently approved in our equity-based system of care analysis. And let's see, let's go one more. So those slides are really the kind of the cusp of beginning to build a forecast. We look at, where are we heading, both long-term from a strategic objective standpoint, and then we look at what are some of the immediate objectives that we have, and we build off of those. So that's certainly useful information as we build our financial forecast. Some of the more significant uses of funds. So now we're getting into the financial forecast, and the first question is, well, what's included in the forecast? So we're looking at a very high level, as it relates to some of our major or significant spends over this period of time. We have included completion of all planned facilities that you, the board, have approved or have been discussed. And then we've also modeled in 2 additional clinical facilities and 1 respite care site. All of those facilities are cash funded with the exception of any previously issued debt. Remember, we had a debt issuance related to Del Valley, Hornsby Bend, and our Hancock site. So with the exception of that, it's all cash funded. Also takes into account the implementation of the EPIC electronic medical record system. And one of the significant uses of funds over time is, as we talk about increasing the direct provision of medical care, and as we build out facilities, it's the increase to clinical staff related to all of that direct care and all of the ancillary services related to that initiative. And so we've modeled in some of those increases, again, at a very high level. And then we've also modeled in some increases to access to primary care services in some of those facilities also. And then last but not least is certainly modeling in a transition to a more direct payment system related to hospital services. Next slide, please. So these are real high level risk areas that exist in most financial forecasts. Economic, I think those are pretty widespread. We live in a highly regulatory environment, so there are some things that we have that produce both uncertainty, but we don't necessarily control all that, have a lot of control around that. And you see that related around both the supplemental funding programs and the local provider participation fund, or the LPPF status, as it relates to some of the ongoing discussions between CMS and HHSC. And then from a regulatory perspective, also just thinking a little outside just the central health proper box as a pair of services. We've mentioned a couple of times our pharmacy program, but even just the degradation of the 340B program and even just the availability of essential pharmaceutical drugs certainly is a risk. And then last but not least are financial risks that exist. And I think these risks have been out in central health for a number of years, but certainly they're still prominent enough to disclose, related around hospital reimbursement programs, our risk-based capital requirements related to our insurance affiliate, and then changes to any FQHC PPS reimbursement rates around the Medicaid population, specifically around community care. So I'm going to turn the presentation over to Lisa to walk through some of the forecast assumptions. Thank you, Jeff. Can you hear me okay?
Yes.
So the financial forecast has assumptions about the sources and the uses. Our sources of funds primarily in the property tax area. For the long-term look, we do have future new construction estimates less than the current year. We saw another extremely significant over $6 billion in estimated new construction this year. That's new values coming onto the tax roll. And we also anticipate, or we forecast, that the taxable assessed values will grow at a slower rate than the current year. And we have a steady straight line tax revenue to kind of reduce that volatility. We look at 5% over year, 6% year over year to see what that straight line tax revenue will do. The other revenue that we have, we do have a few assumptions in there just to continue to receive the tobacco litigation payments and ground lease for the parking garage. As you all are most likely aware, the CEC lease is reevaluated in 2024, so there is an assumption that that would be discontinued. Again, a very conservative approach, and no additional downtown campus lease payments other than the existing agreement. And we also did not assume any third-party clinical revenue. So as we start to lift up clinical services, we don't anticipate significant clinical revenue coming in from those services. On the uses of funds, primarily, Jeff talked a lot about the significant uses of funds over the next 8 years, but in the forecast, we have assumptions about medical inflation, 8 to 10% for our purchased services, and then increases in healthcare service delivery levels at our different facilities, as well as the new services that we will be provided. And in this area, as well as salary and benefits, we will have significant increased infrastructure support for those new clinical services as we lift up specialty care. We, again, also anticipate a transition to more direct hospital funding, a transition of the community care collaborative costs, and continued increased enrollment in our CHAP and ACA high-risk programs. So continued and increased growth in that area for the high-risk premium programs. Another major component of our uses of funds is our salary and benefits. We have accounted for salary increases and health insurance costs increasing, but we've also this year accounted for rapidly changing market demands for staff. As many of you know, it's been very difficult to hire. It's very competitive, and so we accounted for that, as well as we have about 100 new staff that will be projected in the next year's budget to start to lift up that specialty care services that we've heard about at our new specialty care clinic and the new clinics planned in the future to support our specialty care efforts. So in the model, we keep our uses of funds static, and then the revenue changes in the different models depending on what assumption we make on a increase in the no new revenue maintenance and operations rate. So in this model, just to orient you, we did do 8 years this year, as Jeff mentioned, and this one looks at if the no new revenue rate were to increase 5% year over year throughout that period. And our contingency reserve is at a high level now, and you'll see it constantly declining throughout this period. And as you know, a metric that we focus on and we've talked about in years past is that days of cash on hand. So on the right axis, the right vertical axis, you'll see the days of cash on hand targeted is that 120 to 150 days there, that green bar. So in this model, you can see that our days of cash of hand and our contingency reserve is declining over the period as our uses are greater than our sources in the model. And that puts us below our target of 120 days of cash on hand. You'll see down here in the supporting table, it's about 70 days of cash on hand. So if we look at the same model with a 6% year over year, no new revenue rate increase, we still have declining reserves as we are spending our funds on those significant uses of funds that Jeff talked about in healthcare services. And as it declines, it's a little bit better picture as far as the days of cash on hand and the reserves that are available at the end of that period as we ramp up these significant investments in specialty care and patient services provided directly by Central Health, as we've discussed throughout the spring. So this picture looks at that 8-year mark at about 160 days of cash on hand. And again, high level assumptions in this, but this puts us at least at a minimum of that 120 days of cash on hand. So we'll hand it back to Jeff to wrap up. And yeah, thank you. Thank you, Lisa. So yes, so when we went out to get our bond rating, our latest bond issuance, we have to walk through with the rating agencies our financial picture. And they applauded you as the board for taking a really long-term conservative outlook on your budgeting process. And I think these are the tools that you guys have used, the board has used to set the budget. And so they, you know, from a rating perspective, these were all positives that they lauded as far as why we received the bond rating that we received. So, so what does all of this mean, you know, specifically to this forecast? Our reserve levels are high. We know our reserve levels are high, but we know that those reserve levels will be required for future periods related to significant expansion of all the direct clinical care that we've talked about. Also the infrastructure, you know, we build facilities and then we have to staff those facilities. We know that that's, those are significant costs and we need reserves in order to accommodate that over time. We also know that the CCC costs are transitioning beginning fiscal year 2023. We've been planning that for a number of years, and this is exactly what the bond rating agencies are talking about. You as the board saw that. You've appropriately set a tax rate to accommodate that, and it didn't cause any disruption in services. And then certainly just keeping reserve levels high for any, you know, there's always the uncertainty of any federal funding programs that may be significantly changed. And we've seen that. I've been here for a little over 10 years now, and there have been significant changes over that 10-year period. So, and there's no reason why when those happen, they can happen unexpectedly and very suddenly and can have a dramatic effect on how we pay for services. As a note, I think over this period of time, we see our reserves declining. I think we need to look at opportunities to issue debt on some of our capital projects if that opportunity arises. And, you know, we'll certainly monitor that through the approval of projects and market conditions and a number of other factors that we can work with our financial advisors. And then certainly, you know, looking at our overall property tax stability, you know, looking at setting a steady rate year over year that helps us plan as it relates to implementing the high functioning system of care that we've all been planning on for a while, and it's coming to fruition beginning this year and substantially in the future years. So the next slide, based on the information, staff is recommending that we prepare the proposed fiscal year 2023 budget at a property tax rate of 6% over the M&O rate. Again, this is a rate that can change a number of times. It's just a beginning part. It's a starting point for us to prepare the fiscal year 23 proposed budget. So thank you. I know that was fairly quick. I appreciate staff's diligence in the preparation of this presentation, and turn it back over to you, Dr. Bell.
Thank you, Jeff, and your staff for the presentation. Great information. Members, as you know, we will see this again. This is not the first time or the last time that we're going to see this. I'm just going to ask, are there any questions or comments? Please make them as concise as possible. we're running out of time here. So I'm sorry. Oh, okay. So Manager Musaita.
Well, thank you, Lisa and Jeff. Mine is really quick. I know the modeling you want to do for 6%. Can you be a little bit more conservative? Try a model of a less to see how it works, 5% or 5.5%. Because I know last year we did a 6%.
So there are two models included in the presentation.
I may have missed it, sorry.
And okay. And
There was a 5%.
There
So
was?
one, right, there is one model that's 5%.
My apologies. I think it's late at night, but
Okay.
There it is. It's
Okay.
on your screen.
Yeah. So the recommendation
It's 6.
is at 6% because at the very far right, our days of cash on hand, the blue line falls below our targeted 120 to 150 days.
Wasn't it 100 in the past, or am I wrong?
No,
it's always been
no. It's been
100.
120 to 150
Okay,
days.
that was. Thank you.
Sure.
My fault.
Manager Melendez, quick.
Is it okay if I call you and so we can go through this?
Yeah, if you want to send questions, that'd be great.
I do.
Yeah,
I do.
thank you.
Thank you very much. Okay. Thank you, Jeff. And again, thank your staff for the great presentation. Our next agenda item is to receive fiscal year to date healthcare service expenditures made by and accept the preliminary March and April 2022 financial statements for Central Health and Community Care Collaborative and review historical average revenues and expenses for Central Health. Lisa Owens, I'll turn it over to you. And that's agenda item number 3.
Okay, I'm gonna just hit some highlights for Central Health. As you know, we present year-to-date information, so I will focus on April. And so let me try to get this full screen. Okay. So we are at 98% of the adjusted levy, which is right on track with where we were last year. And we are at $79 million of healthcare delivery spending at the end of April. Some highlights from our balance sheet are that there are not any significant changes from what we've presented in the past as far as our assets. However, we did have a LPPF payment that was made in early May, so that $53 million in LPPF cash was paid out in early May. No significant changes at this point to our capital assets, and that puts our total assets at $818 million. On the liabilities, you'll see that corresponding funds held for the LPPF. And again, our current liabilities remain low at just $18 million, and our total liabilities and net assets are also at $818 million. Our sources and uses for the month, we did receive the tobacco litigation fund, came in significantly higher than budgeted, $4.6 million in tobacco settlement revenue. So that's $6 million in total sources of funds this month. And our uses of funds were about $9.9 million, with the majority of that in healthcare delivery. And I'll go into a little more detail there. Our administrative program is at 38% of the year's budget, at about $5 million out of the $13 million budget. In our healthcare delivery program, I'll go through some of the healthcare services in the later slide, but our ACA premium and assistance is right on track at 55%. We do anticipate spending the full budget this year to support that high-risk program. And our campus development continues to fund the finishing up of the demolition, which you've approved additional source uses of funds for that earlier this year, and that work is anticipated to wrap up soon. And then in our healthcare delivery operating costs, we're at about 32% of the budget. Our total healthcare uses were budgeted at $157 million, and we've spent about $60 million of that year to date. I'm going to focus on the healthcare services through our contracted providers or primary care services. We have estimated about $27 million spent year to date of our $60 million budget. And then our specialty care, we did break this out for you to show the direct specialties that are mostly contracted with providers, and then down below those expansion dollars that are starting to be developed as we expand services. But you can see that we have great results where we're expanding services in some of our key areas. And I know that the dollar spent doesn't necessarily show the exact utilization as we've talked about in the past, but we are at 37% of our $11.9 million budget in specialty care year to date. And I am happy to answer any questions or take questions and answer them later.
Okay, thank you very much, Lisa. Any questions with regard to the Central Health financials?
No question, just the ability to get back with you so we can talk in person about this at a later date, maybe next week, okay? Or the following.
Okay.
Thank you.
Great.
Thank you, Manager Valdez. Okay, hearing none. Lisa, go ahead with Community Care Collaborative.
Okay, this Community Care Collaborative. So we are also looking at a very steady year over year. We are in a stronger cash position this year than last year, but our uses of funds and our sources of funds put us at about $1.5 million in net assets. Our assets and our liabilities put us at about $1.5 million in net assets. And we do anticipate one DSRIP payment in July. What you're seeing there is the $500,000 is that, as we've talked about many times with the DSRIP program, we are under continuous analysis of some of the measures that we've received funds for. We continue to have great results and no findings as those measures are monitored by HHSC contractors to look at our numbers. And we recognize this $500,000 out of that reserve because it's no longer at risk. So that's a good thing. But the DSRIP payment will come later this summer. So our sources and uses, primarily all of our uses in the healthcare program, $7 million in healthcare delivery and about $6.1 million in DSRIP project costs. The total uses year to date at $13 million. A little more detail on our healthcare delivery, that $7 million, very consistent with last year with our primary care, specialty care, and behavioral health. And you know that holds our large inpatient contract with Integral Care. So continuing to see those funds spent on patients using that inpatient services. So again, $7 million year to date, about 36% of the budget in healthcare delivery. And I'm happy to answer any questions on the CCC.
Any questions on the CCC financials? Hearing none. Thank you, Lisa. We appreciate all your hard work and the information. And
thank you.
We will go now to agenda item, I think it's number 5.
Is that our last? 5 and
Is it
8.
8 is our last one, but that's adjournment. 5. Agenda item number 5, receive an update on the Central Health fiscal year 2022 support operations as identified in the budget resolution. Mr. Giesland?
Yes, members, this is quick. I just needed to call attention to this memo. It's a holdover from prior agendas that we didn't get to, but it specifically addresses a lot of items, operational items in this current fiscal year's budget resolution that was adopted by the board. Happy to answer questions offline at your leisure.
Thank you very much, Mr. Giesland. I am now on agenda. Manager Valdez?
8. I'm waiting for Sherry to raise her hand.
Okay. Confirm the The next regular board meeting, date, time, and location. Managers, our next Central Health Board of Managers meeting is scheduled for Wednesday, June 15th, 2022, at 5 p.m. at Central Health Headquarters, 1111 East Cesar Chavez Street, Austin, Texas, 78701. At this time, I'm ready to accept a motion for adjournment. Manager Greenberg.
Move adjournment.
Second.
I have a motion from Manager Greenberg, a second from Manager Valadez. Any discussion? All in favor?
Aye.
Any opposed? Motion carries. We are adjourned. Thank
Oh, I want there
you.
to be discussion.
Please don't. Please don't.
I didn't ask questions too. All right, see you tomorrow.
You did good,
Good
guys.
night.
Thank you. Appreciate all your help.
Thank you. And I will email you tomorrow or the next
Okay,
day. or-
Sherry.
I know you're busy. Just call.
Check you
You can
later.
call me if it's too
Okay.
much to email,
Okay.
and we can chat.
Okay.
Go.